One of the most important causes of maternal death is postpartum hemorrhage. And postpartum hemorrhage requires substitution of blood, substitution of volume, substitution of care, and we need to have a very good access to a vein. And as you all know, when we have a woman having bled a lot with a shock, she has collapsed veins. It's very difficult to get a big needle into such a vein in the labor ward. We know that we have one vein close to the medial ankle. That's called the Saphenous vein. And that can easily be accessed by any midwife, any doctor, any health worker working in the labor ward. It is not very easy to train this in real life, but we can do it in a mortuary. And if we have due permission from the hospital director and the ethical committee of a district hospital, we can actually use that particular body to show where is the Saphenous vein. So let's go into the mortuary here and make this exercise together. When we come into the mortuary, it's very important to show respect for the dead body. This is very important. Now, this dead body has been offered to us to train the intervention we are talking about, the Saphenous cut down. And we are just going to take away this sheet and prepare the field of intervention in a few moments. We're going to demonstrate now the few pieces of surgical instruments that we are going to use in this Saphenous cut down. Firstly, we should be clear that we have a IV fluid bag or a plastic bottle like this one. Then we need to have a pair of gloves. We need to have an IV line system, a plastic tubing to be inserted into the bottle. We need to have gauze with alcohol or other disinfectant. We need to cut the skin transversely, a scalpel, curved clamp. We have 2 slings of sutures to lift the vein up, small scissors. The most important thing with this method is to introduce the whole plastic tubing of the IV line into the vein, never using a needle, because the needle will allow only small drips to come down into the vein. That is not sufficient to save a woman's life. We need the whole tubing into the vein. And in order to accomplish that, we need to cut the proper tubing obliquely in order to have a tip of the cut tubing. And that resembles a needle. By that, which we will show you, we can introduce the whole thing into the vein and fix it there with the suture, and then force 1 liter in at least in 1 minute. After that, we have to close the skin incision, and we have a suture here, and then we have the dissecting forceps to keep the skin edges together, and then that's it. A very important thing is to cut the tubing obliquely in this way. This is very important. As you can see, when I tilt it and rotate it, it's like a needle. And that particular tip of the so-called needle will be very important to enter the vein. And this is a trick that we need to know of, because otherwise it's almost impossible to introduce the transversally cut tubing. This is a medial ankle, and this is just anterior to medial ankle. In between my fingers, the Saphenous vein will run here. And I can actually palpate, I can actually feel the Saphenous vein as a very soft thing here, almost like a thin spaghetti structure under the skin. But it's empty, it's collapsed because this is a dead body, but that is where we should put the incision. Normally in a woman not very conscious, in shock, we do not need to run for local anesthesia because this cut is very painless. So this is the medial ankle here, and just anterior to this we're going to make the incision. And after having come through the skin, we make the blunt longitudinal dissection, like this. And in the midst of this structure, hope to find the vein. It comes here beautifully. It's actually here. You see there's little blood here. This is the saphenous vein. We try to liberate it a little bit more without disturbing it. So this is a saphenous vein, and we take one thread below it like that to the distal side and keep it there. And then we take the other one and make a proximal similar sling so that we can keep the vein up. And these two slings help us to identify the veins. Now I'm taking the distal one. We lift the distal sling and we make a small partial cut with the scissor. Should be just half the vein, like that, to open it like a hole like that. And now I'm into the vein. And now I ask my assistants to give me the tip of the needle. And this is again with a very important obliquely cut end, and we introduce the tubing, and it runs smoothly into the vein like that. You can follow it up. It goes into the vein. We stretch the vein a little bit. Now it's in 5 centimeters. We should have it in a little bit more. Now it's up to 8 centimeters more or less. Then I take the proximal thread and I tie it firmly so that the proper tubing is fixed into the vein, like that. So now it's there, and I ask my assistant to compress. This is important to see the flow, the virtual flow. There are no drops seen, but you can see how many milliliters of volume is going into this woman's body. You can see that here is nothing going outside the vein. Everything goes inside the vein. As this vein, you can see here, is filled with fluid going into the body. And this is a very efficient way of getting blood or fluid. And soon we have 1/2 liter in, and we can put another bottle in. And after, we can shout for blood or other better fluid in order to save the life of that woman. After having given this fluid, we can actually try to fix the whole thing and make the suture of the skin. And then I cut the ligature here. I can leave it in place, and then I make the suture of the skin, which is just to make it a little bit less disturbing and avoiding infection. In real life, in the obstetrics, we cover this with this wound with an adhesive, and then we keep it, and it can be kept for 1 day or more. Now, with the respect for the dead body, we should be very careful in leaving the whole thing in a very neat way and withdraw the tubing. And I think we can do it right now after having shown it, so we're not leaving the dead body with the tubing inside. So let's go back and take it away, and I can actually retract the tubing like this from the dead body. It will follow easily, like this. And this is the needle again. And we can say that this small incision will leave a very, very minimal mark on the body. And this is the whole exercise, which is very important for any midwife in the world to perform without doctors, or any non-physician clinician, be it assistant medical officer or clinical officer or anyone working in the labor ward with very severely ill mothers after postpartum hemorrhage.